Most couples over 60 assume that changes in their intimate life are simply the price of getting older. They stop talking about it. They quietly adjust. They attribute what they are experiencing to age and leave it there. But here is what the research actually shows. The majority of physical changes affecting intimacy after 60 are not inevitable. They are hormonal, they are measurable, and in most cases, they are addressable through clinical interventions that most couples never learn about because the conversation never happens. Not with their doctor, not with each other, and not anywhere they are likely to stumble across it. If you or your partner have noticed changes in desire, comfort, energy, or emotional connection over the past few years, this video is specifically for you. Because what is happening has a name, it has a mechanism, and it has solutions. Hello, gentlemen and ladies. I'm Dr. Jocelyn, a board-certified urologist and senior health specialist with over a decade of experience helping adults over 60 navigate the physical and relational changes that come with hormonal aging. Today, we are discussing something that affects virtually every couple in this age group, but is addressed openly by very few. How hormonal shifts after 60 change intimacy, and what you and your partner can actually do about it. And the clinical picture here is more hopeful than most people expect. A 2019 study from the University of Michigan's National Poll on Healthy Aging surveyed 1,002 adults between the ages of 65 and 80 on topics related to sexual health and intimacy. 40% reported that their intimate life remained important to their overall quality of life. Yet fewer than 17% had ever discussed sexual health concerns with their physician. Fewer than 17%. That gap between how much this matters and how rarely it is addressed is the gap this video exists to close. Today, I am going to walk you through 5 critical areas where hormonal changes after 60 affect intimacy, what is biologically happening in each case, and what evidence-based steps couples can take together. If you are in a relationship and over 60, at least 3 of these 5 areas apply to you directly. And the options available to you are far more varied and effective than a single conversation with a rushed general practitioner is likely to reveal. Before we go further, hit that like button right now. Comment below and let me know where you are watching from. This community spans every continent and I read every response. And subscribe so you never miss evidence-based health guidance built specifically for adults over 60. Now, let me show you exactly what the research tells us about hormonal aging and intimacy, and what couples who are thriving after 60 are doing differently. To understand what happens to intimacy after 60, you first need to understand what hormones are actually doing in the background of every aspect of your physical and emotional life. Hormones are chemical messengers produced primarily by the endocrine glands, the thyroid, adrenal glands, ovaries, and testes, that regulate everything from energy and mood to tissue health and desire. After 60, the production of 3 hormones in particular declines significantly in both men and women: testosterone, estrogen, and DHEA, which stands for dehydroepiandrosterone, a precursor hormone that supports the production of both testosterone and estrogen. In women, estrogen declines sharply after menopause, typically completing its steepest drop in the early to mid-50s. In men, testosterone declines more gradually, approximately 1 to 2% per year after 30. But by age 65, many men have testosterone levels 30 to 40% lower than they did at 40. DHEA, produced by the adrenal glands, declines in both sexes steadily from age 30 onward, with levels at 60 typically 50 to 60% lower than peak. These are not abstract numbers. They translate directly into changes in physical comfort, emotional responsiveness, energy, tissue integrity, and desire. One couple came to me together at ages 64 and 67. They had been married for 31 years and described their current situation not as conflict, but as quiet distance, a gradual drift neither of them fully understood. After a comprehensive hormonal panel for both, we found significant deficiencies in testosterone in him and estrogen and DHEA in her. The interventions we implemented changed the trajectory of their relationship. That is not an unusual outcome. It is, in fact, the norm when the biology is properly identified and addressed. The first hormonal change affecting intimacy after 60 is the decline of estrogen in women and what it does to vaginal and pelvic tissue health. This is one of the most physically significant and least openly discussed changes in women's health, and its impact on couples is substantial. Estrogen is responsible for maintaining the thickness, elasticity, and natural lubrication of vaginal tissue. As estrogen levels fall following menopause, a condition called genitourinary syndrome of menopause, or GSM, develops in an estimated 40 to 50% of postmenopausal women. GSM is the clinical term for the collection of changes including vaginal dryness, tissue thinning, reduced lubrication, and increased sensitivity to friction. A 2020 survey published in Menopause Journal found that among women over 60 with GSM symptoms, 63% reported that physical discomfort had led them to avoid intimacy altogether. Not from loss of desire, but from pain. 63%. And of those women, fewer than half had ever mentioned it to a physician. Think of estrogen's role in vaginal tissue like oil in a mechanical joint. When the oil is present, the joint moves freely and without friction. When it is absent, movement causes wear, discomfort, and eventually avoidance. The joint has not broken, it simply needs lubrication. The clinical solutions available for GSM are highly effective and include topical low-dose vaginal estrogen, applied locally, absorbed minimally into the bloodstream, and considered safe for the vast majority of women, including many with a history of hormone-sensitive conditions. Non-hormonal alternatives include vaginal moisturizers used regularly and lubricants used during intimacy. A 2021 randomized trial from the Mayo Clinic found that women using vaginal estrogen therapy for 12 weeks reported a 67% reduction in discomfort and a significant improvement in intimate satisfaction scores. 67% improvement in 12 weeks. Starting tonight, if either partner has been quietly accommodating discomfort rather than addressing it, the first step is a direct conversation with a gynecologist or urologist who specializes in menopausal health. This is a medical issue with medical solutions. It does not require acceptance. One patient, 63 years old, had been avoiding intimacy with her husband for 2 years, attributing it to stress and aging. After a brief consultation and a 12-week course of topical vaginal estrogen, she described the change as transformative. She told me, "I thought this was just what happened. I did not know there was something to be done. I wish someone had told me years earlier." Comment below. Has your doctor ever raised the topic of GSM or vaginal health changes with you? GSM is the most physically immediate hormonal effect for women, but the second area affects both partners equally, and it is the one that tends to quietly dismantle the emotional foundation of intimacy long before either person realizes what is happening. Testosterone decline in both men and women directly governs desire, clinically called libido, and it does so through neurological pathways that are not subject to willpower, mindset, or relationship effort. Testosterone binds to receptors in the brain's limbic system, the region governing emotional response and motivation, and signals the production of dopamine, the neurotransmitter associated with drive, reward, and pursuit. As testosterone falls, so does the neurological signal that initiates desire. This is not a psychological failing. It is a biochemical reduction. A 2018 study published in the Journal of Clinical Endocrinology and Metabolism followed 411 men between 60 and 75 over 3 years and found that those with clinically low testosterone reported significantly lower desire scores, higher rates of emotional withdrawal, and lower relationship satisfaction, independent of other health variables. In women, testosterone, though present in smaller amounts, plays an equally important role in desire, and its decline after menopause is directly associated with what clinicians call hypoactive sexual desire disorder, or HSDD, affecting an estimated 30 to 40% of postmenopausal women. Think of testosterone's role in desire like the ignition system in a car. The vehicle, the relationship, the emotional connection, the physical capability, may be perfectly intact, but without the ignition signal, nothing starts. Low testosterone is not disinterest. It is a missing spark. For men, clinical evaluation of testosterone levels begins with a simple blood test, a morning total and free testosterone measurement. If levels are clinically low, testosterone replacement therapy through gels, patches, or injections is a well-established intervention with significant evidence for improving desire, energy, and mood. For women, low-dose testosterone therapy, not yet FDA approved specifically for HSDD, but widely used off-label with strong research support, has shown consistent benefits in clinical trials. Beginning this week, if either partner has noticed a gradual reduction in desire that feels disconnected from emotional interest in each other, schedule a hormonal panel. Do not attribute it to aging and accept it. Investigate it. One patient, 66 years old, came to me describing what he called a loss of initiative, a feeling that desire was simply gone, not situationally, but categorically. His testosterone was at the low end of the clinical range. After 6 months on testosterone replacement therapy, he described a return of what he called normal motivation. His wife, separately, told me the change in him had changed their relationship. He told me, "I thought I had simply gotten old. What I had was a deficiency. Those are not the same thing." Hit that like button if the testosterone desire connection clarified something for you. Testosterone governs desire at the neurological level. But the third hormonal shift affects something more subtle, and in many ways more consequential for long-term intimacy, which is the regulation of mood, emotional availability, and the capacity for connection. Declining estrogen in women and declining testosterone in men are both strongly associated with increased rates of anxiety, irritability, emotional reactivity, and low-grade depression in adults over 60. These are not personality changes, they are neurochemical ones. Estrogen modulates serotonin receptor sensitivity, meaning that as estrogen falls, the brain's ability to regulate mood through its primary stabilizing neurotransmitter is reduced. Testosterone in men has a parallel relationship with dopamine and norepinephrine regulation. A 2017 meta-analysis published in Psychoneuroendocrinology reviewed 43 studies and found that postmenopausal women with low estrogen showed significantly higher rates of anxiety and depressive symptoms, independent of life circumstances. Similarly, men with clinically low testosterone showed elevated rates of irritability and emotional withdrawal that normalized with testosterone restoration. The compound effect on a relationship is significant. When one or both partners are experiencing hormonally driven mood dysregulation, the emotional availability required for intimacy, the patience, the warmth, the desire for closeness, erodes quietly. Couples begin to feel like roommates. They argue more easily, they connect less naturally, and neither person understands why, because the cause is invisible. Think of it like a dimmer switch on emotional connection. Hormonal decline does not turn the light off. It gradually dims it, so slowly that neither person notices until the room is considerably darker than it used to be. The actionable path here is two-directional. First, clinical. A comprehensive hormonal evaluation that includes not just testosterone and estrogen, but thyroid function, DHEA levels, and cortisol, because adrenal fatigue compounds hormonal mood dysregulation significantly in this age group. Second, relational. Couples who understand that mood changes are biological rather than personal make fundamentally different interpretive choices. Irritability becomes a symptom to investigate rather than a grievance to manage. Starting this week, if emotional distance or mood changes have been a pattern in your relationship, approach the next conversation about it through the lens of biology rather than blame. Schedule the hormonal evaluation together. One patient couple came to me after describing 2 years of increasing conflict that neither could explain given their otherwise stable and committed relationship. Both partners had significant hormonal deficiencies. Both began appropriate therapy. Within 4 months, they described their relationship as better than it had been in a decade. She told me, "We were not failing each other. Our hormones were failing us. Understanding that changed everything." Comment below. Has mood change or emotional distance been something you have noticed in yourself or your relationship? Mood and emotional availability represent the interior architecture of intimacy. But the fourth hormonal area affects something men rarely discuss, and its silence creates a specific kind of damage to both partners that compounds over time. Erectile function in men over 60 is directly tied to testosterone levels, vascular health, and nitric oxide production. and all three are affected by hormonal aging. Erectile dysfunction, or ED, affects an estimated 52% of men between 40 and 70, with prevalence increasing significantly with age. By 65, approximately 65% of men experience some degree of ED. Yet a 2020 survey by the American Urological Association found that fewer than 25% of men with ED had ever discussed it with a physician. Fewer than 25%. The biology is specific. Testosterone supports the production of nitric oxide in penile tissue, nitric oxide being the signaling molecule that triggers smooth muscle relaxation and allows blood flow necessary for erection. As testosterone falls, nitric oxide production decreases, vascular responsiveness diminishes, and erectile reliability declines. This is compounded in men with cardiovascular risk factors, as arterial stiffness further reduces the blood flow response. A 2019 study from the European Association of Urology found that men who received testosterone replacement therapy in conjunction with phosphodiesterase 5 inhibitors, the class of medication that includes commonly prescribed ED treatments, showed significantly better outcomes than those on either intervention alone. The combination addresses both the hormonal signal and the vascular response simultaneously. Think of erectile function like a hydraulic system. You need both adequate pressure, blood flow, and an intact signaling mechanism, hormonal and neurological, for the system to operate correctly. ED in most men over 60 is not a structural failure. It is a systems failure with identifiable components, each of which can be addressed. The clinical pathway begins with a full cardiovascular and hormonal workup, because ED in men over 60 is frequently an early warning sign of cardiovascular disease, preceding a cardiac event by 3 to 5 years in some cases. This makes the conversation with a physician not just relevant to intimacy, but potentially life-saving. Starting tonight, if ED has been a silent presence in your relationship, name it. To your partner first, then to your physician. The options available in 2025 are vastly better than they were a decade ago, and the evaluation itself may reveal cardiovascular risks worth knowing about independently. One patient, 67 years old, came to me having not mentioned ED to any physician for 4 years, managing it privately and allowing it to quietly reshape his relationship. His evaluation revealed both low testosterone and early-stage arterial stiffness. We addressed both. His urological outcomes improved significantly. His cardiologist intervened on the vascular findings early. He told me, "I came in embarrassed about one thing and left knowing I had avoided something far more serious. The conversation I had been avoiding may have saved my life." Hit that like button if you believe more men should be having this conversation with their doctors. The cardiovascular and hormonal dimensions of erectile function are critical. But the fifth and final area is one that affects both partners in a way that is rarely framed as hormonal. And yet the research is unambiguous about its biological roots. Physical affection, touch, and the desire for non-sexual closeness are regulated in large part by oxytocin, sometimes called the bonding hormone, and its production is directly influenced by estrogen, testosterone, and overall hormonal balance. As estrogen and testosterone decline after 60, oxytocin responsiveness, the degree to which touch, closeness, and physical affection produce feelings of warmth and connection, diminishes in many adults. This is why some couples over 60 describe a general reduction in physical affection that goes beyond sexual intimacy. Less spontaneous touching, less comfort-seeking, less of the small daily gestures that form the connective tissue of a long relationship. A 2021 study from the University of California, San Francisco, found that postmenopausal women with lower estrogen levels showed reduced oxytocin release in response to physical touch compared to women on hormone therapy, suggesting that the hormonal environment directly modulates how physically connected partners feel in everyday interaction. In men, testosterone supports oxytocin receptor sensitivity, meaning that as testosterone falls, the neurological reward from physical closeness is reduced, even when the desire for connection remains. Think of oxytocin's role in a relationship like the mortar between bricks. The bricks, shared history, commitment, mutual respect, remain. But without mortar, the structure gradually loosens. Hormonal decline reduces the mortar. The bricks do not disappear. They simply hold together less firmly. The actionable steps here are layered. Clinically, addressing the underlying hormonal deficiencies in both partners restores much of the oxytocin responsiveness over time. Behaviorally, research supports deliberate physical affection practices, extended physical contact, non-sexual touch, and what researchers call skin-to-skin bonding time, as direct stimulants of oxytocin release that can partially compensate for reduced hormonal sensitivity. A 2018 study from the Kinsey Institute found that couples over 60 who maintained daily non-sexual physical affection reported significantly higher relationship satisfaction and lower rates of depression than those who did not, independent of the frequency of sexual activity. Daily touch matters, not as a prescription, as a practice. Beginning this week, build deliberate physical affection into your daily routine as a couple, not contingent on mood, not contingent on where the hormonal picture currently stands. The habit itself generates the neurochemical signal. One patient couple, both in their early 70s, described having gradually stopped touching each other casually over the previous 3 years. Not from conflict, but from a drift neither had fully noticed. I gave them one instruction: 15 minutes of physical closeness every evening, without agenda. At their 3-month follow-up, both independently described feeling more connected than they had in years. She told me, "It sounds almost too simple, but simple was exactly what we needed." Comment below, is daily physical affection something you and your partner practice intentionally? Now let me give you a complete, actionable protocol to take everything covered today and put it into motion. Tonight, have an honest conversation with your partner about which of the 5 areas resonated most. Not a problem-solving conversation, simply an honest one. Name what you have both been quietly experiencing. Starting tomorrow, schedule a comprehensive hormonal evaluation for both partners. The panel should include total and free testosterone, estradiol, DHEAS, thyroid function, and cortisol. Many of these can be ordered through a primary care physician, urologist, or gynecologist with a single appointment request. Starting this week, if vaginal dryness or discomfort has been present, consult a gynecologist specifically about GSM treatment options, including topical estrogen therapy and non-hormonal alternatives. Do not wait for your physician to raise it. Raise it yourself. Also this week, build one daily physical affection practice into your routine. It requires no medication, no appointment, and no cost. It simply requires intention. This month and ongoing, if ED has been present and unaddressed, make the physician appointment. Frame it not as an intimacy conversation, but as a cardiovascular one, because that is what the research supports. The evaluation may reveal information that matters well beyond the bedroom. One couple I want to tell you about implemented this full protocol over 6 months. Both were in their late 60s. Both had significant hormonal deficiencies. Both pursued appropriate therapy. They added the daily affection practice from week 1. At their 6-month check-in, he described his energy and motivation as restored. She described her physical comfort and emotional availability as transformed. Together, they described their relationship as the closest it had been in 20 years. Not because they found something new, because they addressed what biology had quietly taken away. Gentlemen and ladies, here is what you need to understand. The changes most couples over 60 experience in their intimate lives are not failures of love, effort, or commitment. They are the predictable biological consequences of hormonal decline, measurable, identifiable, and in most cases, addressable. Estrogen decline creates physical changes in women that are treatable. Testosterone decline reduces desire in both partners through neurological pathways that respond to clinical intervention. Mood dysregulation driven by hormonal shifts is a biochemical reality, not a character flaw. Erectile dysfunction affects the majority of men over 60 and is both treatable and diagnostically important. And the quiet erosion of daily physical affection has a hormonal mechanism and a behavioral antidote. The University of Michigan study found that fewer than 17% of seniors had discussed sexual health with their physician. That number needs to change, starting with you, starting with your partner, and starting with your next doctor's appointment. Starting tonight, have one honest conversation about what you have both been noticing. That conversation is the beginning of everything else. If this video helped you, hit that like button right now. Comment below and tell me, which of the 5 areas today was most relevant to your own experience? Your answers are read, and they shape what I cover next. And subscribe for more evidence-based health guidance for adults over 60. New videos every week. Now, if you want to go even deeper, watch this video next. It covers how testosterone decline after 60 affects energy, muscle, mood, and metabolism, and what the latest research says about restoring it. I'm Dr. Jocelyn. Understanding your biology is the most powerful act of care you can offer yourself and the people you love. Take care of yourselves.